Welcome to our noon lecture series. Today is an extra special day. I have the pleasure of introducing Dr. Selwyn Rogers. He is our section chief for trauma and acute care surgery here at the University of Chicago and has been in this role since 2017. He's also the Dr. James E. Bowman Jr. Professor in the Biological Sciences. Dr. Rogers is an acclaimed trauma and critical care surgeon and public health expert who has served in leadership capacities at health centers across the country. Here at UChicago, he has helped launch the Violence Recovery Program, which we talked about a little bit last week, in conjunction with the Urban Health Initiative. His work seeks to improve quality and access to care for all patients and advocate treating intentional violence as a public health problem. Dr. Rogers has also served as the chair of surgery at Temple University, as well as the division chief of trauma, burn, and critical care at the Harvard Medical School at the Brigham and Women's Hospital. At the Brigham, he also helped to launch the Center for Surgery and Public Health, which serves to understand the nature, quality, and utilization of surgical care nationally and internationally. And so I'd like us all to give a warm welcome to Dr. Selwyn Rogers. This is such a treat.
Good afternoon. I'm going to get this mic on. One second. I thank everyone for braving the cold and coming into a cold room. Can folks hear me okay? Is the microphone working? Okay, so I'm a bit of a wanderer. Given that I have spent my academic life in Boston, Philadelphia, and Nashville, and Dallas, and Texas, and now Chicago, but Chicago has become home, and so I'm glad to be home, and I'm glad to be, if you will, in the house that Dr. Mark Siegler built in terms of the new field that he created of clinical medical ethics. And the MacLean Center is a testimony to the power of relationships and vision that Dr. Siegler has embodied over the course of his illustrious career to culminate in a lecture series like this one. And I thank Dr. Prochaska, who's not here at the moment, who invited me over the summer. And my wife was here, loves to say I have a little bit of FOMO, fear of missing out. So I often say yes to things before stopping to think about what I just said yes to. But this is a honor to be here. And I hope that I can share with you a few thoughts on advocacy and its role in addressing equity in trauma care. But I will also say that as someone who is a bit practiced at giving talks, if you want to stop, ask questions, interject, I just will not relinquish the microphone. But anything short of that, if there's something I say that doesn't make sense, or something that you want to provide a counterpoint, you will not take me off my game because I know where I'm going. You may not, but I do, and I will get there, and then we'll have some time for questions. One of the great things about joining the University of Chicago in 2017 was the incredible assets across the university. And one of the assets certainly is the MacLean Center. So in January of 2017, I arrived, I left Galveston, Texas, and that day it was 75 degrees, and I landed and it was 15 degrees like today. And I said to myself, I must be committed. I better go get a pair of boots because my feet are cold. But with that being said, day 3, I still didn't know where the bathrooms were, at least the nearest bathroom. And Dr. Siegler and Dr. Angelos came to my temporary office. And as they said in the movie The Godfather, gave me an offer I couldn't refuse. And that was largely to help launch that year's in 2017's MacLean Center series, which was focused on violence, trauma surgery, and ethics. And we had a wonderful year, and I kicked off that year's lecture series October 4th, 2017. And I won't forget it, but I actually did forget it because so many things have happened since that time. And back then, October of 2017, what I talked about was all theoretical. It was based on past experiences at multiple other trauma centers and was largely around the question, what was the trauma center at the University of Chicago going to be? So now 7.5 years later, I'm going to tell you what the trauma center is and a little bit about where the trauma center is going. There are a couple of people in the room that know parts of this story, but there are also lots of people who are not in the room who know many parts of the story much more in depth than I do. And I'm going to try to take you on a little tour because what I hope to impart upon you is the powerful role of advocacy in having impact in the space that we work every day with people who we care for and care about. And the challenge that I pose to you is, what is your part in this space of advocacy for the patients that we serve? So with that being said, you can't really have a talk without disclaimers. And my disclaimer is none, unfortunately. So I have no financial disclosures, but I do have a couple of disclosures. I'm tall. I'm black. I'm male. Identify as cisgender. And I'm happily married to this wonderful woman who's my better half. And everyone tells her that she's better than me. I still don't quite see it. No, I'm just kidding. She is better than me. But let's start with a definition. Just to lay the foundation. Anthony Douglas is one of my fellows who works with us and the academic trauma surgery focus on advocacy. And it's a bit of a complicated discussion, and I'm doing definitions, but I chose to use Wikipedia, not encyclopedia, but Wikipedia. So this is proud for its definition of the word advocacy. An activity by an individual or group that aims to influence decisions in the political, economic, and social institutions, and can include a number of activities and publications to influence public policy, laws, budgets, by using facts. It's not an assault on facts, by using facts, their relationships, the media, and messaging to educate government and the public. And what I hope to share with you is the multi-sectoral nature of advocacy in the space of trauma care and hyper-local review the history of trauma here at the University of Chicago. And my exposure to advocacy happened way before I walked through the hallways of the University of Chicago or even walked throughout the south side of Chicago. And no story about trauma can ignore the story of Benjamin Wilson. And I'll start with this story because it's an important one to set a framework for what we're talking about. So Benjamin Wilson was the Michael Jordan of his time. He was what the NBA now calls positionless basketball. If you know nothing about basketball, he could play all 5 positions on the floor. He was 6'8", 220 pounds, young man, 18 years old, in this picture, who could handle the ball, had a handle, he could point guard, he could shoot, so he was a shooting guard, Michael Jordan's position. He was strong enough and quick enough that he could play small forward, and he was a good rebounder, so he could play power forward, and he was tall enough that he could defend the other team's tall player, so he could play center. So he was multi-dimensional. And he was going to be the next star in the NBA. At the time, there was a rule that you had to go to college for at least 1 year before being drafted. So right around the era of LeBron James is now 40. Right around 20 years ago, you could leave high school and go to the NBA. But back then, you had to go at least through 1 year of college. And Benji had the world at his feet. He was being recruited at Illinois and Indiana. Paul, back then, Paul was actually good. And he could have gone in. And he was in the midst of deciding where he was going to go to college to play basketball before going to the big show. And he was in a relationship with a young lady, who he actually had fathered a child with. And they left school, giving Rice the church, at lunch to get something to eat. And he did nothing more than just literally bump into someone leaving the store. And that should have been nothing more than start or what's wrong. And that little interaction with someone that he didn't know escalated like that, like a wildfire. And the 18-year-old that he bumped into saw this 6'8", 220 giant of a boy man who said, "What do you mean?" And unfortunately for Benji, that 5'11", 18-year-old had a bad day and also had a gun on him. And he pulled the weapon, feeling threatened by Benji in this interaction that went from 0 to 60 in milliseconds. And he shot Benji in the groin and then from back. Now, this is a world-class athlete who could tolerate running a half marathon and then do it again. And so he literally was bleeding to death on the streets, not that far from here, on the south side, and was taken to St. Bernard Hospital, community hospital that's not that far from here, actually 2 miles from here. Because then you took the person to the nearest hospital. And when he arrived, there was no surgeon, there was very little blood in the hospital, there was no FFP, there was none of the things that we think about that are currently embedded in trauma centers across the United States. And it took 4 hours before a surgeon arrived. By the time Benji went to the operating room, he died at night. Now, when Benji died, he was so well known that 10,000 people came to his funeral. But because it was such a public death, it led to change by the Illinois Department of Health around trauma care. The Benji rule became, if you are most severely injured, you have to go to a trauma center. And back then, and still is, the cutoff is 16 and under, you go to a children's trauma center, like Coma, or older children. And 16 and over, you go to an adult trauma center. But back then, University of Chicago had an adult trauma center, but he didn't come to University of Chicago because back then, the algorithm was to take the person to the nearest hospital. Benji's dad changed that rule. If emergency medical providers, fire department, EMS brings you to a hospital after a severe injury, you had to be taken to a trauma center that's designated. Now, people can take people anywhere in the hospital, to any hospital they want to. But if you're going to be transported by professional services, those are the rules. Now, the reason why this rule was powerful is that it affected what happens next. So I tell you about one 18-year-old boy, teenager. This is another 18-year-old boy, teenager. Damian Turner was a community activist, social influencer for the current label of influencer. And he, too, was 18-year-old Black teenager who was advocating for rent control here on the south side of Chicago. And he led a group called Fearless Leading by the Youth. And that group was advocating for a whole number of things back in August of 2010. August 2010, August 15th, 4 blocks from here, 4 blocks, he was shot in the back during the day. Because of the Benji Wilson rule, he had to be taken to the adult trauma center. He was 18 and a trauma center. But the University of Chicago at that time, August of 2010, did open heart surgery, did transplant surgery, liver transplants, complex GI surgery. Those are all component parts of what trauma does. And he was whisked by University of Chicago and arrived at Northwestern dead. His mother the next day said to the press that if the University of Chicago had had a trauma center, my son would still be alive. Now, you may know that this was reported in the New York Times. So it became a national story. So it went from being a local Chicago story, a local Southside story, being blown up as a national story. And then that's where advocacy really took off with respect to the fact that a set of actions happened because the community awoken to have advocate for the level of trauma center in University of Chicago. When that advocacy took off, it took off largely because of these facts. So you don't have to really look very closely at this map. This is an old map of Chicago, 2014. Every dot represents someone shot. And if you look closely, there is a concentration of black dots here and here, west and south of the city of Chicago. We call the south and west side of Chicago. And the fact of the matter is, if you look at the red dot, red squares, and the squares that are red and yellow represent both being an adult and pediatric trauma center, some things should strike you pretty quickly. There is only one yellow square, former pediatric trauma center on the south side of Chicago. But there's all of these black dots around Homer. And the community pushed hard for a trauma center on the south side because there was this relative trauma desert on the south side of Chicago compared to the rest of Chicago. And the group that Damian Turner led, Fearless Leading by the Youth, catalyzed many groups throughout the south side, including students, providers, churches, community organizations, to advocate for level one trauma centers. There were sit-ins and die-ins and disruptions or graduations and disruptions of fundraising and shutting down Michigan Ave to demonstrate and advocate for an adult level one trauma center on the south side, specifically at the University of Chicago, as the only anchor at academic medical center on the side of Chicago. And one of the things that struck me about this, I told you it's the advocacy started in August of 2010 after the Turner's death. The first major activist event was in the fall of that year. Fall of 2010. 2010. Filed at 437 homicides. 95% of those are by gun violence. 437. 2012 for 406, and I don't have to read the numbers for you to see that for yourself. Something dramatic happened in 2016. Now, you may remember there was this little presidential election back then. Chicago became the poster child for urban violence. Became shorthand for racialized crime. But there was also a very dramatic, another 17-year-old boy who was shot 16 times with Juan McDonald that year. And unfortunately, in a Van Dyke police officer pulled his service weapon, and for a kid who had mental health challenge and disturbance, was wielding the knife and walking away. The officer pulled his weapon and emptied 17 bullets, 17 billboard. And this became incredibly problematic because it was at the same time that body cameras were increasingly being used by police officers. And in a fit of, I'm not going to use the word security, they chose to try to cover that up, despite the fact that there was body camera film. And it turns out they probably didn't read the manual, but the body cameras go on automatically after a certain period of time. That led to a couple things that are hard to fully explain, but at the same time that 2016 was going on, the spike in violence in Chicago went to another level. So there were 754 homicides in 2016, 645 in 2017. And this became a national story about how violent Chicago is and how that we needed more rigorous policing as a response to the degree of that, as President-elect Trump called it, the carnage in Chicago. But one of the things that's striking about this reality is before 2018, when the Trauma Center opened here, about a third of all Chicago's violent crimes happen within 5 miles of where we sit. Now, Hyde Park itself is incredibly safe, right? It has both Chicago Police Department, but its own University of Chicago Police, and so the degree of issues within our local environment, Hyde Park, one of the safest communities in all of Chicago, is relatively low. And obviously, it's important branding if you're going to have your kids come to University of Chicago. My middle son is that out. You want your kids to feel safe. You want your employees to feel safe. So it was a significant problem for the university. And with the context of advocacy, the push for Trauma Center was really around the issue of this life by one of my faculty at Hampton to geomap distance to Trauma Center. In this particular case, red is bad. Not sure why it's really red. But red is bad, it just reflects the further distance you are from the Trauma Center. And in this particular case, green is good. Look at where all the trauma centers are in Chicago, at least for adults. Disproportionately in some of the communities. And with the advent, hypothetically, the trauma center here in Chicago would create this dynamic where all of a sudden the South Side of Chicago has ready access to the trauma center. To stand up a trauma center, I always love to say, George Clooney and ER ruined that costume in my life. Because he made it seem that it was pretty easy to be a emergency medicine physician and deliver a baby and do a pulmonary embolectomy, and the person goes home in 2 days and they hear it looks perfect. But a trauma system is not a trauma surgeon. It is a system care that highly stereotyped, highly orchestrated with a lot of people. A new emergency department has to be built with trauma bays and resources and policies and procedures. And all of that is the work, the hard work of a dedicated team of people who are willing to be, if you will, test cases, willing to be a bit maverick in order to stand at the trauma center in a place that had no institutional culture around trauma care. And there was so much that we all had to learn together that when I said I am coming to the operating room now, I don't mean 12 hours from now. I mean like the next 5 seconds. And that was an incredible cultural shift for the organization, as well as many other things. This is who we started with. You can see everybody's coat is white. There's no vomit, no blood. And we all look well rested. But this was one day before. We actually went out to dinner that night, if I remember correctly. We all had the old meeting of homes. The trauma center opened May 1st, 2018. And I'm gonna linger here for a second because we spent a lot of time on this mission statement. And except for prepositions, there's only one word that appears more than once. That word is community. Trauma center was a response to community active. Community activism, community advocacy for the trauma center. And we were the stewards of their efforts over the course of 27 years, but intensified over the preceding 7. We started off with 7 faculty. This is what the faculty look like now. What do you think we all are doing? A lot of people. Well, and we've started a fellowship. What are all these fellows doing, and residents and advanced practice providers? Teams of people trying to save lives. The lives they're saving are these. When we were first opening, projected for a trauma center for adults, in conjunction with our Tacoma Trauma Center that has existed for 30 years, we were projected to be at 3,000 trauma activations a year at trauma center. We're at 6,000 trauma activations. The other thing is, if you look at this graph, the top graph is total, and the bottom graph is penetrating. And when I say penetrating, I mean not a fall, not a car accident, not an assault. I mean a knife or a bullet. And 90% of our injuries on the south side of Chicago are sadly bullets. And when we first opened, I think we were all a bit daunted by the fact that about 38 to 39%, the number one reason why you came to the trauma center here in Chicago is you were shot. That is so AV normal. Most trauma centers across the country, like 8%, 5%. We're in the top 1% of mechanisms of injury, especially. When you think about that for a second, what does that mean in the 7.5 years that we've been open at the trauma center? Just our single trauma center here in Chicago I've seen over 8,000 people shot. 8,000 people and counting shot. And some days, I remember I try to keep tabs on my trauma faculty, and I think there was one particular night I don't sleep at night. I woke up at 3 and I saw the pager go off. I reached out to the coach who's sitting up there and said, "How you doing?" And we had 3 traumatic breaths in a row. There are 2 words in the silence. It's just daunting when you see. And this doesn't really tell you the lived experience and what people are affected by when a bullet or multiple bullets traverse their body. And sadly, for less than 16-year-olds, about 1 in 5 children, less than 16, come to Comer's emergency department having been shot. That's the highest in the country. So what's our role as advocates, witnessing, bearing witness to this sad reality that, as you know, is not unique to Chicago. In fact, by rate, total number of gunshot wounds, total number of injuries, by rate, the highest mortality rate for gunshot wounds in the United States of America is where my wife grew up, in Wilkes. Cities like Hartford, Connecticut have higher rates of gun violence than Chicago. But because of our size and relative to other cities like Los Angeles and New York, we remain an outlier. So no city gets to be 800, which is what we were in 2020. The sad reality is, from what gets projected in the media, we only hear that number. There was the end of last year into this year, there was discussion about making a goal to have less than 500 homicides in the city of Chicago. Let me give you a frame of reference for a second. The last time Chicago had less than 400 homicides in a year was the year I was born, 1967. Chicago now has less than 400 homicides by the 66. And in the late 70s, early 80s, as many as 900 died of gun violence per year in the city of Chicago. So these numbers are daunting when you think about it. But what drives those numbers? I think it's easy to make a narrative, bad people doing bad things to bad people who deserve it. Is that a narrative that we want to say focuses on equity? So this is not math. Anyone was trying to figure it out. 85 is the average life expectancy in Streeterville. 69 is average life expectancy in Washington Park. 16 years of life lived, separated by 8 miles of geography or 7 stops in LA County. And now this gets repeated. The numbers are kind of the same, 15, 20-year difference life expectancy. But some cities like Boston, it's as little as 2 miles. So when I trained in Boston, Brookline, as a Brookline Country Club, has some of the highest life expectancy, some of the greatest wealth. Roxbury, which is 2 miles away, has some of the lowest life expectancy. And there's this little community hospital. There's a small hospital, large hospital in the middle of it, Brigham Women's Hospital, I trained. And those are 2 different worlds in the same city of Boston. And that is true in San Francisco, it's true in Milwaukee, it's true in Hartford. North, south, west, east are the only distinctions from city to city. And it's driven by the social determinants of health, where people live, work, play, train every day. And those are the biggest drivers of these disparities that we see. And the disparities related to trauma are also reflected in disparities in wealth, disparities in economic opportunities, disparities in educational opportunities, disparities in neighborhood contexts. And when we talk about trauma, it's easy to focus on the event from the shock. That's where all the resources currently go. The event. We have emergency medical services, we have trauma centers, we have systems that take care of people after they're injured. There's some resources for people to rehabilitate. But if anyone in this room has ever been injured or had surgery, what you want more than anything else is not to just be okay. You want to get back to what you were doing before. You want to be fully recovered, physically, emotionally, psychologically, and spiritually. And that's actually quite hard. But we don't often talk about the built environment or lived experiences. And what I mean by built environment, again, is how people live. It's how the Rand Corporation says, if I know your zip code, I can tell you the life expectancy. It involves your educational opportunities, tells you a lot about the environment in which you live, tells you about safety, tells you about streets, it tells you about bike lanes, tells you about parks, green space, all those things. It's health. And on top of that, in the city of Chicago, a great city, love Chicago, city of neighborhoods, 77 communities make up this great city called Chicago. But it's striking how from one side of Damon Ave to the next side of Damon Ave, we have two different parts of the world in one city called Chicago. And if you look at economic opportunities, for example, economic hardship index, some communities are more distressed than others. That also is reflected in unemployment rates, particularly on the south and west side of Chicago, particularly in Black and brown communities, and also in terms of high school graduation rates. And all those things are intersectional factors that drive health outcomes and drive violence. When you look at the issue of who are the victims of violence, going from left to right, left is shootings in the city of Boston, middle is life expectancy, and on my right, it's economic hardship. And in this particular case, economic hardship, the darker the hue, the more hardship you experience. The middle graph, the darker the blue, the shorter your life expectancy, and the far left, the lighter the color, the more gun violence. And no one has to be a statistical expert to see that there's full linearity for all these factors. So what do we do about this, right? Nobody in this room can end racism. No one in this room can end income inequality. All those things are driving what we see in the trauma center and in the trauma base. This is some work that Bethany Strong, one of my former residents of the Brigham, did when she was in her fellowship at the University of Maryland Shock Trauma, one of the oldest trauma centers in the country. This is my only real sciencey slide with an actuarial survival curve. The top graph, people shot once and only once, and the bottom graph, people shot more than once. Show of hands, please. The line is one of them. Top line and the bottom line. Okay, you don't want, right? You don't want to be on this at all. However, there's opportunities for those who end up on one of these lines. And the point of this is, if you've been shot once, the opportunities never to shoot shot again. And sadly, we know that there is about 40% chance in 5 years being tried again if nothing happens. And so that's an opportunity. And hospital-based violence intervention programs, most notably shock trauma initially, like 20 years ago, and also at University of California, San Francisco, a wraparound project, basically try to address this issue of trauma recidivism by addressing these social determinants of health, giving people opportunities at jobs, retraining, changing the arcs of their lives so that they weren't re-traumatized. Hard work, but necessary work if we're going to interrupt the cycle of violence. And Rochelle Dicker and her group at UCSF have shown that not only can this work save lives, but also save money. In the case of San Francisco, there's only one dominant trauma center in the city of San Francisco. Now, San Francisco is a lot smaller than here in Chicago. And so most people who are traumatically injured, be it firefighter, police officer, or the person who lives on Manassas Ave, will go to UCSF's trauma center. Here it's much more diverse, maybe more hospitals, much bigger city. And so the chances of us knowing for sure that something we took care of here doesn't come back someplace else is actually something we're working on right now. One of the real hard things about this work that it's not straightforward. This is not pipetting cells. This is not doing PCR machinery. This is about human lives and complexity of human lives. So we try to have wraparound services for our patients here with our hospital-based violence intervention program that we call VRP, our violence recovery program. And we use the moment in the hospital to establish trust and build relationships with our patients and their families in an attempt to accompany them on the journey to recovery. Getting a bit cold. And this is where it's really hard because it's about changing behavior and changing lives. And how do you do that, especially given the complexity of people's social and religious experiences? We've been blessed that a combination of the Urban Health Initiative and supportive philanthropic resources from the Block Haslam Foundation has supported helping us go from 2 violence recovery specialists to now 20. We were optimistic at the beginning, Monday to Friday, with our violence recovery team. Now we're 24/7, and increasingly looking at how can we establish more rigor in terms of the dose response to the individual patient and accompany them on their journey of recovery beyond just the hospitalization into the community. And that's work that we're going to turbocharge over the next several years. And then as I come to close on my comments, this work is pretty complicated. These are just some of our partners. There's work going on across the city for both community street outreach as well as social services network. And the things that we focus on in the hospital, fixing broken bones, stopping bleeding, restoring physiological function, even though they're hard, they're actually much easier to do than this work. This work involves us being partners with our community and all the things that go along with partnerships. Sometimes that could be messy, sometimes it's glorious, but it's not straightforward. And we have to continuously work at it because it constantly changes. City of Chicago currently has gotten enough folks engaged with public safety being a fundamental right for all of Chicagoans. And so the business community has recently committed $100 million to help expand community violence intervention. And that in partnership with the city and community-based organizations, we hope will be a sustainable catalyst for improved safety for all communities in Chicago. We're also, being a research-intensive university, we're trying to lead the way in innovation through rigorous research. One of the opportunities that we see with our patients is they often have health harming legal needs, and that doesn't mean legal needs related to defending themselves for a criminal case. This is about workers' comp, and there is a pot of money that people can have access to through the federal government called Victims of Crime Act funding, and preventing people from getting evicted because they can't pay their rent. Those are all things that us in the room have a credible agency about, that many people who lack agency don't know if we have it. So we've actually started a novel structural intervention called our Recovery Legal Care Program, which partners with Chicago Legal Aid, and we have NIH funding, $5 million worth of it. Dr. Zackerson leads to help us understand what people need and can we implement this in a way that's scalable. And we're hoping over the next 2 or 4 years we'll get information that helps us inform what the rest of the country does. This is one example of how this Recovery Legal Aid can help patients. People often may not know that they have access to supplemental nutrition assistance food, and that know that they can have access to other social services that can get them resources to help them and their family. And these are real dollars that are not new apportionments. They're not new. There's no legislation that has to be written. They're ready money that's out there that people just have to get access to. But if you lack agency, how can you get access? And then finally, what can each of us do? One of the things that I think has always been inspiring to me is, if you quote the great Martin Luther King Jr., you don't have to carry your burden, your soul. I'm paraphrasing. Anyone can serve. And we all can serve because in the context of the work that we do, we have agency. We have the ability to pick the phone. When people live here, all the state legislature, they'll listen. All the service, they'll listen. But a patient who's shocked in the holiday might doesn't have that. When you do. And how can we amplify our voices? It's like in very important listener. So I've been able to use my voice to give voice to those who don't have voice in a couple different settings, your Senate, House of Congress, and it helps to change the narrative about how this affects real people. Not a statistic, it's not a number, it's real people, real lives, with real effect. And the other thing that I personally like to do, and it's a form of therapy for me, is I like to write. Help when my insomnia or the prior state. And when something really bothers me, that inspires me to write about it. So I've written a number of op-eds about various issues that intersect in this space. One thing that bothers me in the media is when a 16-year-old man gets shot. Last time I checked, there's no such thing as, how do we work out? Some of it happen. And we all have our voice, and there are all ways that we can advocate for the patient that we serve, oftentimes because they can't advocate for themselves. So I'll leave you with my favorite quote. Never doubt that a community group of people change the world. Thank you for your time and have a good one. Bit of time. Yeah.
So when there's sort of that upswing of gun violence and homicide in